Hello, good afternoon or evening or possibly morning, depending on where you're joining us from. Thank you so much for being here today as we present to you on the topic, Am I Too Early to Start LSVT BIG or LSVT LOUD? This is put on by LSVT Global, and I'm going to go ahead and just switch to the next slide and just briefly introduce myself and my co-presenter here. My name is Beth Peterson. I'm one of the LSVT LOUD training and certification faculty members. I'm a speech-language pathologist, and I've been working with the LSVT LOUD clinical research team since about 2009. Most of that research is done at the National Center for Voice and Speech in Denver under the direction of Dr. Lorraine Ramig. I'm joined today by my colleague Heather Cianci, and she's a physical therapist, and she works at the Dan Aaron Parkinson's Rehab Center, and she's one of the LSVT BIG training and certification faculty instructors. So we're very excited to be here today to present to you on this exciting topic and very important topic with early Parkinson's and the treatment approaches that are available. I do also want to acknowledge some of our co-authors who helped work on this presentation because there's been a lot of work put into it, a lot of brain power, and I think we have a nice presentation here today. So Angela Halpern, Dr. Cynthia Fox, Heather Hodges, Laura Gousset, and Lorraine Ramig all had a part in this presentation as well. So I'm going to briefly go over the plan for the webinar here today so you know what to expect. First of all, everyone in the audience, your microphone is automatically muted, and that's just to make sure that we don't have background noise from the various environments where you may be joining us. There is a handout attached to the webinar. So if you look on your webinar control panel on your computer screen and you click on the plus next to handouts, you'll see two handouts listed. One is a listing of all the webinars that we have, and the second one is the handout for this webinar here today, so that you can save that or print it and take notes on it so that you'll have that for your reference. There's also additional information on myself and Heather within the presentation, and I'll cover that in just a minute. So really the plan for today is Heather and I will review and discuss early Parkinson's and then how it can be applied to LSVT LOUD and LSVT BIG. And then we have a lot of information to cover, but we do want to have some time at the end to discuss any of your questions related to early Parkinson's and intensive behavioral treatment. There's also a survey at the end of the webinar, so it will pop up on your screen right when you X out of the webinar. If you have time to take that, we really appreciate your feedback. It should only take a few minutes, but it really helps us make sure that our webinars are beneficial to you, and then also gets feedback to see how we can improve and any other topics that you would like to hear about. If you do have questions during the webinar, or especially at that Q&A section we'll do at the end, there are a few ways to ask your questions. The first is to type in your question, and you can do that by clicking on the plus on your question panel on your webinar control panel, and then type in your question. I'll see the text of your question, and then I'll read it out loud, and either Heather or myself will answer it. You can also raise your hand, and you can do that by clicking on the hand icon on your control panel. Then I'll see that you have a hand raised, and I'll call out your first and last name and unmute your microphone. Then you can ask your question out loud to the group, and either Heather or myself will answer it that way. If you think of questions after the webinar, you can always email us. So it's info@lsvtglobal.com. And we have different experts for both the LSVT BIG and LSVT LOUD who are happy to respond to any questions that you may have. This is just a little bit more detailed information about my background and Heather's background. So if you wanted to look over that, that's included in your handout. And in terms of disclosures, so all of the LSVT Global faculty have both financial and non-financial relationships with LSVT Global. The non-financial relationships include a preference for LSVT LOUD and LSVT BIG as treatment techniques. And then any equipment that we discuss in the workshop also is part of that disclosure. I'm an employee of and I receive lecture honorarium and travel reimbursement from LSVT Global, and Heather receives honorarium, consulting fees, and travel reimbursement from LSVT Global. We do have some videos to show you during the presentation here today. So all the clients that are seen in the videos have given consent for their videos to be used for educational purposes, but no participants are able to copy those videos or view outside of this webinar without permission. So we just have that up there to make sure that we are able to maintain that consent with the patients. So in terms of learning outcomes, at the end of this webinar, we hope that participants are able to summarize the common mobility and speech and swallowing issues facing individuals with early Parkinson's. Also list how early therapy can help with brain change in very positive ways. Also be able to list how early therapy can lead to better mobility, speech, and overall quality of life. And then describe how LSVT BIG and LSVT LOUD can help individuals with early Parkinson's. So before we get started with the treatments, we do want to really kind of back up and define what is considered early Parkinson's disease. So it's defined as 5 years or less since diagnosis and Hoehn-Yahr stages 1 to 2. And I should say there are some varying definitions on this, but in general, that's what's kind of seen as considered early Parkinson's. So just to quickly go over the staging, so this is the Hoehn-Yahr scale, and if you are an individual who has Parkinson's, you may be familiar with this from your neurologist, you may have that rating. So we're looking at stages 1 through 2 here to be considered with early Parkinson's disease. And with early Parkinson's disease, it's not early in Parkinson's disease, and this slide here will kind of demonstrate that to you to see how the course of the disease presents. So here on the left, what you see is a subsection of the substantia nigra, and you see pigmented areas. So this is with someone that did not have Parkinson's disease. So you see that pigmentation, that coloring on that side. If you look on the right side, you see the same area, the same section with a loss of that pigmented areas. So we have that depigmentation, and it's showing up in that section there with Parkinson's. So at the bottom of the slide, you see that there's a 50 to 60% cell death at the time of diagnosis. And then 70 to 80% loss of the dopamine agonist terminals can precede the diagnosis by about 5 to 6 years. So if we think back to that definition I just showed with early Parkinson's being within the first 5 years of diagnosis, if someone's been diagnosed, they're 5 years post-diagnosis, really those neurological changes could have been going on for about 10 years. So we see here started about 5 to 6 years before the diagnosis, then they were diagnosed, and now it's been 5 years post-diagnosis. It's been about 10 years since those changes have been going on. So when we say that it's not early in the disease, it's because those changes happened even before diagnosis. So we're already progressing further along in the disease there. So what symptoms can be detected in early Parkinson's? And so we'll kind of break this up between the speech symptoms and communication that you may see, and then also some of the limb motor system changes you'll see. So previously, kind of the medical chart review literature was all that was really available for speech and swallowing symptoms. And what was seen there was suggesting really a mid or late stage onset of those type of symptoms. But more recent investigations with more sensitive and valid measurements do consistently report speech and swallowing symptoms very early in the course of Parkinson's. And some of those speech changes that are very common early on in the disease are reduced loudness or monoloudness, or monotone, so not really any variability in the pitch, or hoarse, harsh, breathy voice quality. And along with that, individuals can also be perceived as bored, disinterested, or apathetic. And you can see how that can really have a difference. For example, if someone's still working or very active in the community, and others see them as bored or disinterested, you can see how that can really affect their quality of life in those outside situations. So some things that clinicians will do when working with individuals with early Parkinson's, since those symptoms may not be quite as overt as someone that's later on in the course of the disease, we may have to unmask the deficits. So it might be that you could come into a treatment room, you're sitting one-on-one with a therapist in a quiet room, and you're able to be heard and understood just fine. However, it might be that if you speak for longer periods of time, or if you add some type of motor task or a cognitive task to it, it may be more difficult to keep your volume up or keep a good voice quality. So that's what the clinician would do in working with you to kind of unmask the deficits, we say. So they would use some dual tasking with assessments. So during some of the tasks that you would do in a treatment session, what if we add in a motor task? So what if we have you unbutton a button on a shirt, or unzip something, or tie your shoe? Are you able to maintain that same loudness and quality that you do when you're just focused on your voice? So this kind of added load might unmask that soft monotone voice that we are seeing even early on in Parkinson's. We also look for negative impact on communication participation. So If you work with a speech language pathologist, they may also give you kind of a survey of questions related to your voice and see how it may affect your quality of life and participation in communicative situations. So then we can identify subtle changes that a person might not overtly identify with changes in speech and voice. So maybe you are noticing, oh yeah, when I go, to my poker club, people aren't talking to me as much, or I'm seeing people lean in. So it might be that you didn't really notice those changes before, but then when you're more in tune to them, or kind of have that list of a survey of questions, it might help you see, oh, maybe this is related to my communication. Some other non-motor characteristics related to communication can be, so even individuals who are clinically asymptomatic for speech deficits do report feelings of embarrassment, social stigma, and isolation due to speech concerns. So even, again, if those changes aren't so overt, they may be noticing changes in their overall interactions with other individuals. So does this matter? And so the consequences can include being excluded from conversations, or feeling a loss of dignity, or feelings of misery for many individuals. So this is research done by Nick Miller out of the United Kingdom, and really dug into this, what are the effects on quality of life for these individuals, even early on in the course of the disease. So I'm going to turn it over to Heather, and she'll talk more about the limb motor system changes that we're seeing.
Great, thank you so much, Beth. So some of the things that we as physical therapists and occupational therapists notice within our patients in these early stages are what we call an asymmetry of symptoms, meaning that Parkinson's always starts on one side of the body and then progresses to the other side. So we may often see that someone has not been swinging their arm, or they're catching one foot in particular when they're walking, catching it on the floor, maybe a little more shuffling, or sometimes even tripping. We can see that the neck and the trunk have some rigidity, meaning that there's some more tightness and stiffness in there. We also start to see subtle changes in coordination and balance. So people are generally not falling at this stage in the game, but they are starting to see some changes in when they have to do many things at one time, or that maybe when they're being rushed. We do start to see those gait changes that I mentioned before, with the lack of arm swing and the lack of hitting the heel on the floor. We do get that shuffling, and changes the speed of someone's gait. And we know that the slower that someone walks, the more likely they are to be able to lose their balance. The other thing that we see a lot of is alteration in your perception of movement, and that's what we talk about in LSVT BIG as well as LSVT LOUD, with this motor sensory disconnect, meaning that oftentimes people are not aware that they're not taking a large enough step, or they're not aware that they haven't been swinging the arm. And then when we as therapists come along and say, hey, we really need to take a bigger step, or we need to swing that arm, they may think that we're crazy and say, well, that's just too big and that doesn't feel right, when in actuality it is the amount of effort that they need. So that loss of automaticity, before you didn't think about having to swing the arm or moving your trunk a certain way. And then difficulty with really trying to stay organized and trying to do many things at one time, even two things at once. We notice that when we test someone with walking, we get a certain score, maybe in their speed, but if we have them do another task, or perhaps we have them carry a glass of water, or we ask them to name as many different animals as they can in a category, in a certain amount of time, that it actually slows down the person because it's very challenging for them to do those things. The thing that is often troubling to me is when people are misdiagnosed, and if that arm on one side hasn't been swinging for a long time, people can end up with a tendinitis or rotator cuff problem. It may have been seen incorrectly by an orthopedic doctor, when in actuality the underuse of that arm is really due to the underlying symptoms of Parkinson's. And then in the non-motor system, we're talking about anxiety and depression can be kind of underlying sometimes even before the actual motor symptoms. And we know that a lot of people suffer from sleep disturbances. And when we know that we are not fully rested, it makes our work-life schedule a little bit more crazy and a little bit harder to manage. And with all those underlying changes, it can be a lot for people. So we really try to work with people in all of these situations. Next slide. So we hear people all the time say, you know, my symptoms are managed really well with medication. Why do I need intensive therapy now? Well, Beth and I are going to talk to you about why we need to do that, because we really want to prepare the brain and repair the brain. So we don't want to wait until things have progressed too far. We want to get you when you are early in the course of your disease so we can really drive brain change. So let's take a look at the next slide and we'll talk a little bit more about this. When we're talking about brain change, we're talking about a word that you may have heard before, neuroplasticity. And neuroplasticity essentially means that we are making changes in the brain, that we're getting new receptors, that we're getting new pathways, new parts of the brain are starting to talk to each other. And we know that it is in that early phase, or that initial phase, when the neurodegeneration takes place, that most of the neurons are lost. So early on, if we can get in there and stop those neurons from being lost, we can really have a good impact. So this is the time when the treatment can have the most impact on preventing that further degeneration. And with further degeneration, hopefully slowing down those symptoms. And I just think this quote is just so important. It says, if exercise plays a powerful enough mitigating and palliative role, it should be performed very early and aggressively, and ideally prophylactic years before the onset of the process. So certain people who are genetically predisposed to having Parkinson's disease should absolutely be starting an aggressive program. And again, those in the early stages and our people who are young onset Parkinson's, this is again where we are going to push very hard, because that's the way that we're going to make that brain change happen. Next slide. So when we take a look at this slide here, I know it looks like it's a lot of information, kind of busy, but let me take you through it. We're looking at the amount of time across the bottom line going horizontally. And if we look at the up and down line there, the vertical line, that's the percentage of remaining dopamine neurons. So we're looking at, starting out, everybody 100% of those dopamine producing neurons. And as people are moving into the stages of Parkinson's, we can see that preclinically, before people even start to maybe even show signs of a tremor or something else that is coming about, we're starting to see that 20% of those neurons are actually lost. And people start to actually test at a decreased amount of physical activity. And wouldn't it be wonderful eventually with research if we could get to the point of neuroprotection and we could stop that from happening? Where we are now is in the early signs where people start to see changes. They start to notice that their voice has changed, it's quieter, it's more monotone, they're starting to notice those movement changes. And like Beth said before, they're at the point where they've already lost upwards of 60% of those dopamine producing neurons. And that's where patients start to see the diagnosis. They go to see the physician, and that's where they're actually said, you know, told this is the diagnosis, this is Parkinson's disease. So if we can get into that block of time right there for neurorestoration, then we're way ahead of the game. Because unfortunately, if we wait until those later stages where people are really starting to have problems with swallowing, articulation, balance problems, really a loss of true mobility, and oftentimes that is when people are referred to therapy where they're already starting to have really excessive symptomatology. Now we're working on compensations, and that's not where we want to be. We want to get to people as soon as they are diagnosed, and then we can really make and drive that true brain change. Next slide. So what types of exercises are going to drive neuroplasticity? Let's take a moment to talk about that. The key ingredients to any program when we are looking at specifically neuroplasticity is that it has to be specific. So it means that those exercises that we give you really should target the specific symptoms that you're having, and they need to be functional goals. So if you're having difficulty with trying to get up from a chair, I'm not only going to just strengthen your legs in the hopes that if your legs are stronger, you'll be able to get up out of the chair better. What I am going to do through LSVT BIG is I'm going to push you to actually get up and down from several different chairs, several different ways. So it's specific to the difficulty you're having. And again, it's very intensive, meaning that we're pushing you to the point where you are getting tired, you're exerting energy, you are feeling like you are working out. and that it has to be meaningful to you. So it has to be something that is specifically important to you. So we want to work with you as therapists to make sure, what are your goals? What do you want to accomplish through therapy? How can we help you to maybe start doing some of the things that you stopped doing because of Parkinson's disease, because you were worried about things? And the last one there is repetition. And that means that we can't just practice that with you once, expect you to get it, and then be on your way. If you think back to when you first learned to ride a car, you first learned the home row with keyboarding, or you learned cursive, it took a lot of repetition and a lot of practice. And that is the same expectation that we have to make the brain change, is that we need to push it and make it very repetitive. Next slide. The other things are complexity, meaning that these exercises should never be boring and they should never be easy, meaning that as soon as you, I like to say, stick the landing. So as soon as you get it right, then we make it more challenging for you, and we make it more, just the environment more challenging and more fun. And we'll show you some videos and talk more about that. And we know that timing, we have research that really suggests that the sooner we start, the better. We're going to get more results the closer we are to time of diagnosis. Next slide. So we think about that use it or lose it principle. So meaning that if we fail to drive specific functions in your brain, then it means that we're going to have more degeneration in the brain. So we like to say, we're not going to use it and lose it. We're going to use it and improve it, meaning that we are going to train you how to drive specific brain functions so that you really will have much greater enhancement of whatever the function is you want. If you wanted to be able to talk louder for a longer amount of time, if you wanted to be able to now return to going hiking, or you wanted to be able to not have to have someone give you that little extra push to get up out of the chair, then that's what we're going to work on with you. Next slide. So there's research behind what we're talking about, and what we're looking at in this specific study here is that they actually had people working on a treadmill. So they were doing high intensity walking on that treadmill. So they were really working hard. And what they found is that these people had something called increased cortical motor excitability. So excitability is a marker for how severe Parkinson's is. So they found that that actually changed by doing that, and they found that people actually had more dopamine receptors in their brains. So they were more dense, they were healthier, they were able to accept the dopamine that was still available in the brain. And they also found that these people had more volume in the gray matter in their brain. And the gray matter is really important because it really does contain most of the brain's nerve cell bodies. And those are the regions that are involved in controlling our muscles and in our sensory perception. So things that are very important for us. And then two of these neurotrophic factors. These are neurotrophic factors help to support the health of our neurotransmitters. They help things to work efficiently, and they really keep the cells that we have in our brains very, very healthy. So all good, positive things from that. Next slide. And this is one of the research studies that I think it really highlights the importance that we can have early on in the course of the disease. This study looked at 40 people who were newly diagnosed with Parkinson's disease, and they followed them for 2 years. And they broke them down into two groups. One group that was only taking medication, they were taking Azilect, that's the once a day pill, and the other group took the Azilect but also performed an intensive exercise and therapy regimen, where they did 2 28-day multidisciplinary, meaning that they were doing PT and OT, and they really worked these people for a long time. You can see here they were tested at 6 months and 1 year, 18 months, and then the 2 years. And they were tested on a whole host of functional abilities. And what they found was at the end of this testing series that the medication group really didn't make any good changes, and they actually needed more medication in the long run. And the people who actually were optimally medicated, so taking that Azilect, but then also performing that therapy, they improved in all of their functional measures, and they actually ultimately needed less medication. So it gives us really good justification for why we need to push people so hard, so specifically, and so early. Next slide. So I'm going to turn this over to Beth now, and she's going to talk to you more about the evidence for LSVT LOUD.
All right, great. Thank you, Heather. So yeah, we'll talk a little bit about LSVT loud, the evidence that we've seen with early Parkinson's in particular. So I'm going to just kind of walk you through some of the research studies that have been done. Overall, with LSVT loud, what we're seeing is a cross-system change of effects across the whole speech production system. So not only are we seeing changes and improvements in vocal loudness, but we're also seeing improvements in articulation and swallowing, facial expression, respiratory or breathing, so respiratory kinematics, aerodynamics, PET imaging, so changes in the brain and what's being activated, and then also perceptual changes, so changes that another listener can identify. So this just kind of shows you overall the types of changes that we're seeing with LSVT loud across all stages of the disease. And then from that research, we have pulled out a subset of participants with early Parkinson's. And so what you see here, so on the vertical axis here, you have decibels of sound pressure level, so that's vocal loudness, measured at a distance of 30 centimeters. And then here on the horizontal axis, you see pre, post, and follow-up. So pre is right before beginning treatment. Post is right after treatment. So that's after 4 weeks or 1 month of treatment. And follow-up is 6 months after they finished treatment. So we see in blue, we see the group that had Parkinson's disease that was treated with LSVT loud. And the orange line here, we see the untreated group. So both groups had early Parkinson's. They started right about the same level of loudness, and you see a huge jump for the group that received LSVT loud to post, and then also maintain those gains out to the 6 months of follow-up compared to the group who was untreated, who pretty much stayed right at the same loudness level. So we are seeing changes in those individuals with early Parkinson's. More recently, and this is current research that we're analyzing now, we did another randomized controlled trial that had 84 subjects. We broke up the subjects into 4 groups. 2 received different types of intensive treatment and 2 groups remained untreated. So I'm going to just quickly show you the subset of participants from that new research with early Parkinson's as well. So we're seeing very similar changes that we just saw in those earlier studies. And here on the left side of your screen, again, you see changes in decibels of sound pressure level, or vocal loudness. And then going from baseline to post, so from pre-treatment to post-treatment. The solid line is LSVT loud, and the dotted line is the group that was untreated. So again, we're seeing those nice changes in sound pressure level, so nice changes in vocal loudness compared to the group that didn't receive any treatment. On the right side, you see changes. This is called the Communication Effectiveness Index, and so that abbreviation is the SETI. And so we see, as I was mentioning before, when we give individuals with early Parkinson's a rating scale, or kind of a participation scale of how communication affects basically their quality of life and what changes they've noticed, we see that their answers or their responses on that rating scale improved after treatment, so indicating that they're also improving communication and noticing those improvements in communication after treatment versus the group that was untreated. So we have these smaller subsets of participants with early Parkinson's that we were able to pull from the larger studies, and we see that absolutely there's changes to communication and that those changes can improve with intensive voice therapy, LSVT loud. So another question that we get is, well, I already exercise regularly, and that could be body exercise or voice exercise. So people might say, oh, I already sing, I'm in a singing group. Why do I need to do therapy? So we've listed the top 4 considerations with thinking about doing intensive therapy. So therapists, both speech and then also physical and occupational, are movement and voice experts in Parkinson's, and they'll be the best ones to educate you, establish a baseline, and help you design a customized or individualized exercise plan specific for your needs. So general fitness does not include functional task-specific training that is important for your life now and later. So just as Heather was saying, that specificity really matters for that neuroplasticity or that brain change, to make sure we're working on the things that you are encountering every day in your typical life. So for example, singing does not improve your speech. So we definitely don't want to say don't continue to sing or do any of the fitness programs you're already doing. But you do want to make sure that you are doing something very specific for the needs that you want to change. And the same way with movement. If you take a boxing class, again, that's great to get overall exercise, but it's not going to teach you how to better button your shirt faster. So again, we need to be very specific in what we work on in therapy. So therapists also understand the underlying pathology to assure that exercise is safe and comprehensively addresses your Parkinson's. So again, very individualized to your needs and safety. And also, general fitness does not address the sensory deficits in Parkinson's that Heather was mentioning. So we're also focusing on making sure that that new loud voice or those new bigger movements are movements that you're able to do outside of treatment as well. Because with Parkinson's and those sensory deficits, it may take some time and more energy to get used to how it feels to have a louder voice and have those bigger movements. So that needs to be addressed during therapy to make sure that you'll take those changes out of the therapy room and apply them to your everyday living. So what we want to see is kind of this chain of events. So we have the diagnosis of Parkinson's disease, and then most likely you'll be on some type of medication to optimize function. But then we also want to have that therapy with that to optimize function and then guide the exercise recommendations. With therapy, it's not that you could do your month-long intensive therapy and then completely stop doing any of those intensive exercises ever again. Just like if you went to the gym and got yourself really strong, really in shape, and then you stopped doing all those workouts, you wouldn't expect your body to remain in that type of shape. So it's the same thing with these intensive voice and body programs. You'll need to continue to do some daily exercise practice at home, in your community, and your everyday living. And then we also have what are called therapy tune-ups. So after you finish your month of treatment, it might be that after 6 months, your therapist will check in with you, see how you're doing, and then maybe have you come back to the clinic and do a couple more sessions to get you tuned up and back into that louder voice, those bigger movements. And then repeat. So keep continuing to do those exercises, continuing to do that home therapy. We really say it's a lifelong process. So how can LSVT LOUD and LSVT BIG be applied early on in early Parkinson's? So I'm going to specifically talk about LSVT LOUD, and then Heather will talk more about LSVT BIG. So LSVT LOUD is consistent with principles of neuroplasticity, so that make those changes in the brain. It's administered in an intensive manner to really challenge that impaired system. So some of the ones I'll kind of just briefly talk about over the next slides are specificity. So again, training the deficits that you want to improve. So in the case of voice, training that vocal loudness is a lot of what we work on. Intensity, so frequency, effort, repetitions. So it's an intensive treatment program, both every day that you go to therapy and then intensive in the dosage, and that it's 4 days a week for 4 weeks. Complexity, so we're working on complex movements, and specifically with LSVT LOUD, making it complex that you're speaking for longer durations, possibly doing some multitasking. We'll have you speak in different types of environments so that you get used to using that loud voice and all types of situations and all types of environments. So salience, we are also practicing rewarding tasks to keep you motivated, engaged. It really activates that basal ganglia circuitry. So we'll talk specifically about those 4 and how they're applied within treatment, and then we'll also talk about use it or lose it and use it and improve it after a few slides here. So before we go into each of these, I do want to show you a video. This is an individual, she had early Parkinson's disease. Her name's Lucy, and you'll see her pre and post LSVT. So you'll see her right before starting treatment and then after the 16 sessions of treatment.
Well, I should have brought in a tape today. I did a demo tape of voiceover work just a few months ago here in Denver. I had it produced. And I went to Loretto Heights College in 1981. I graduated with a degree in acting and a minor in dance. Plus I had vocal training, both in speech and diction and private voice class. I have gotten a power under my voice that feels real comfortable, and I feel like my voice is alive again, that when I'm having my downtime and my body is shaky and stiff and my face kind of gets a little frozen, that I can still bring my voice alive. So, and it's in communicating with people like at the store or something. it makes them more comfortable to be able to hear that I'm a very together, happening, normal person with a body problem that doesn't intimidate them as much.
Okay, so with her, and sorry, I should have mentioned that sometimes with the webinar, the video, what you see lags behind the audio. So hopefully you still got the to hear that video pretty well, even if it wasn't really in sync with how you saw her moving. But with her, you could see that pre-treatment or before she began treatment, she was, you could still probably hear and understand her okay. So her symptoms were more subtle, but you could definitely tell after treatment that she had that power under her voice. She had that confidence to communicate. I mean, you could see that shine through in her face and then also in what she was saying. So that's what we're seeing with treatment. So we're seeing those nice changes in I like that word, that power under her voice. And then also that overall confidence to be able to be heard and understood in all situations. So let's break down the LSVT LOUD treatment concepts so you can get a sense of what treatment looks like. So with LSVT LOUD, the target is going to be a loud voice. And we say that loud is more than a laryngeal event or more than just actually working on your voice box and making your voice get louder. And we see that spread of effects into other areas as well. So at home or wherever you may be watching this, I just want you to say hello in your normal voice. So if you say hello in your normal voice, this little image on your screen is likely what your body and your face looks like. So now I want you to say hello in a loud voice. So hello. And so without even thinking about it, when you increased your loudness, what we see here, we see an improvement in respiration. You likely opened your mouth more, your lips, your tongue, your jaw moved more, and out came louder, more intelligible speech. And also, some other things to point out, your vocal folds likely closed better as well. And so even though we're only focusing on vocal loudness, we're seeing this nice overall spread of effects, just like you saw in that earlier study, that slide that showed all the studies that have been done. So loudness is kind of this trigger to spread effects across a whole speech production system. So as the client, you would only be thinking about loudness, but we're changing all these other areas of communication as well. So the mode of delivery is an intensive and high effort approach. So treatment would be delivered 4 consecutive days a week for 4 weeks, and these are individual 1-hour sessions. So it's one-on-one with your speech language pathologist. So there's multiple repetitions to keep you intensively exercising the whole session, all 16 sessions. In addition to the 16 sessions of treatment, you also have daily homework practice and what we call daily carryover exercises all 30 days of the month. We're really working to get you into a lifelong habit of practice. And this is consistent with practice principles that drive that activity-dependent neuroplasticity that we've been talking about. This is what the session would look like. So the first half of every session, we do daily exercises. And the first exercise is a maximum duration of vowel phonation. So it's a long, loud ah, and you would do that at least 15 times. Then we do maximum fundamental frequency range, so high and low ahs. So you would do something like ah, so that would be a high ah, and again you would do 15 of those. And then a low ah, ah, so keeping that loud voice while going low. And you would do 15 of those. Then we have maximum functional speech loudness exercises. So those are what we call functional phrases. Your therapist would work with you to have choose 10 phrases that you say every day in your daily habits. So it might be good morning or what's for dinner, did the mail come yet? And you would repeat those in therapy as well as outside of therapy for homework. And I should say that for the other ones, you would also do the ahs, highs, and lows for homework as well. The second half of the session are what we call hierarchy exercises. So that's where you take those that loud voice that you worked on in the first half of the session and apply it to variable speaking conditions. So in week 1 of treatment, you would work on your loud voice at the word or short phrase level. And you'd gradually build up across the 4 weeks of treatment. At the end of 4 weeks, you're going to be speaking in that loud voice in regular conversation. So that's the goal after those 4 weeks, to have that new loud voice become your new voice all the time in everyday conversation. Again, you're going to have homework all 30 days of the month and what we call carryover exercises, which is an opportunity to use that new loud voice outside of the treatment room with somebody else in your daily living to see what type of impact that you have or what they notice when you do that carryover exercise outside of treatment. So just an example so you can see how this is functional and applicable to daily living. Even though we're doing that exercise, the end goal is that now you have a louder voice in conversation. So we might always come back to that exercise that really revs up your voice, and we bring it back into, let's use that voice when you answer the phone, or when you call your doctor today, or when you call your sister. So that's the end treatment goal, is to have that louder voice in everyday conversation. We also address calibration, and that has to do with the sensory deficits that Heather was talking about again. So this can address the barriers to generalization. So what we like to say with LSVT Loud is if you don't feel like you are talking too loud, you're not talking loud enough. So it takes that much effort to get to that louder level, to have that within normal limits loudness, to make sure that you're comfortable with that new loud voice, and it's a voice that you'll use outside of treatment. So we're retraining that sensory perception of the amount of effort and loudness needed to speak within a normal loudness level. So those address those first 4 plasticity principles of specificity, so training that vocal loudness, intensity both within and across sessions, complexity because we're increasing the complexity across the 4 weeks of treatment with different types of reading and conversation activities, and then salience. So we're working very much on activities that are meaningful to you. So readings that your therapist chooses are going to be readings that you enjoy. So they'll ask you for your hobbies or what you're doing for work, and those are the types of readings that they'll pull for you for treatment, so that those tasks are very salient to you. So now we'll just briefly talk about use it or lose it, and use it and improve it. So as Heather was saying, use it or lose it. Failure to drive that specific brain function can lead to functional degradation. On the other hand, if you use it, you can improve it. So training that drives a specific brain function can lead to an enhancement of that function. So we just have a couple of quick diagrams to really show that point here. So with this one, pre-treatment, so you may have noticed a softer voice, and then you may notice also that you're not as successful with communicating. So then you are withdrawing more from social situations, and so we say that you're caught in this soft voice cycle. So you have the soft voice, you're not confident in your communication, so you're withdrawing from social situations or even certain work tasks or volunteer tasks, and then you just continue to go in the cycle because not using your voice will continue to make it softer, so again, falling into this vicious cycle. So what we want to happen is to break that cycle by using it to improve it. So with intensive salient exercise, now you have this louder voice, you have more success, you have more confidence, so you have less opportunities, or I shouldn't say opportunities, you're not withdrawing as much. So now you're this confident communicator, so now you want to use your loud voice more, so you're using it and improving it, and that's what we want to see to help make those changes in the brain. So what do we hear from individuals as treatment progresses? So I hadn't realized how much I was repeating myself until I didn't have to do it anymore, or I have so much more confidence with communication. My voice doesn't feel wiped out at the end of the day anymore. And that's really with early Parkinson's. It might be that you're able to be heard and understood early on in the day, but especially if you have a job or activities that are very demanding of your voice, it might be that you're just so fatigued at the end of the day, you aren't able to, or you don't have that endurance to keep that loud voice going. So that's how treatment can also help, especially early on in the disease. Or I love how people interact with me now. So it might not be with early Parkinson's that you're hearing people say, oh, what a nice loud voice you have now, but it might be, oh, my poker buddies aren't leaning in anymore, or I can tell that people are more engaged with me when I go out to dinner with them. So these are some comments that we get from individuals after completing LSVT Loud. So now I'm going to turn it over to Heather, and she'll talk about the limb motor system and how LSVT BIG can be used.
Great, thank you, Beth. So much like LSVT Loud, we have different sections where we work on exercises, but we also work on functional tasks as well. So with us, we start with our maximal daily exercises. There are 7 exercises, and all of the exercises are meant to help you understand how you can move better functionally. So if we look at exercise number 3, the forward step, that can be really helpful for people who are not taking a large enough step and are getting their foot kind of in that shuffle, or they're catching their foot when they're trying to step up the stairs. So all of those exercises really are kind of a primer to get you to think about how to function better. Our other part is something called functional task components. And those are 5 everyday tasks that we have you do. One of them is always going to be sit to stand. So for someone who is in the earlier stages of Parkinson's disease, you may not be having a lot of difficulty with generally getting up from sit to stand. Maybe you have more difficulty if it's a low soft couch or a very low toilet. So what we do is we take that sit to stand and we make it incredibly challenging for you. So you may be sitting on a low stool that has a pillow on it, or we may be having you put your feet on a balance pad. So we really try to make it very complex for you. And then we choose 4 other tasks, that things that you do every single day that you either want to get better at or something you're worried about having difficulty with. So maybe pulling your keys or your wallet out of your pocket, the ability to type, maybe on that affected side, you're having a little more slowness and stiffness and you're just not quite hitting the keys at the right pace, or you're hitting things a couple of times when you didn't mean to. So we work with you to figure out functional component tasks, the things that you can practice over and over again that'll really be hooks for you, that every time you go to pull your keys out of your pocket, you'll think about doing it with more effort and with bigger movement. We always work on walking with you, so we're going to vary the distance and the time, but we're also going to vary how challenging it is. So it may be inside, it may be outside, it may be skipping, it may be having you walk over very uneven surfaces. We may be having you walk and toss a ball, or it might be asking you movie trivia questions while you're walking, all in order to work on that dual tasking so that you can get really good at doing multiple things together. So we're really taking it up to a much higher challenging level for you. And then we also have something called hierarchy tasks. And again, those are things that you help identify with your therapist that you think you could do better. So maybe it's getting on and off the bus, it's setting up your workstation, it might be going out hiking. I have a gentleman right now who has a 55-pound dog, and the dog will simply not move for him in bed. So he's trying to figure out a better way to get in and out of the bed and get his body around where the dog is. And that's one of the tasks that he wanted to work on. So we're performing that in our clinic. And then lastly, we give you carryover assignments. So we give you a little, we give you homework to do, but on top of that, we give you a special task of something that you're already going to do that day where you really have to show off your bigness. Next slide. So again, these are the exercises here. The picture that you're going to see here is that forward step where we take that nice big step forward, we stomp the ground, and then we open up the arms and pull them back. And then we return back to that starting position. So again, 7 different exercises that your therapist will work with you on throughout the program. Next slide. So again, those neuroplasticity principles, we are working you hard. You're doing multiple repetitions of these exercises. We're pushing you from a strength standpoint to see if you can hold the movements, if you can stick your landing. We're also challenging your balance by putting you on different surfaces. We're making it complex. So again, I talked about the dual tasking where we might be walking and tossing the ball. And then again, the repetitions, we're doing hundreds to thousands of repetitions over that month that you are with us. And then again, the specificity. So anything that you're doing too slow and too small, we're going to work on making those movements then larger and therefore faster and much easier for you to be able to produce. Next slide. So we're going to see a video here now of one of the exercises.
You want to start with your feet in a big posture. Big step forward and nice and big and wide. Now you're going to begin to rock forward and backwards with a big rocking motion as you go. Now let's begin to add your arms. So big reach, big rock. Big reach, big rock. Now we're going to switch your feet and we'll do the exercise again. So put your other foot forward. Big step, nice and wide. And we're going to begin to rock back and forth big. Add your arms. Get your movement going. And we'll start the count now.
And we can pause that video now. So you can see how that exercise, even though it's technically an exercise, how that can relate to something very functional for you, with being able to swing your arms, with being able to shift your weight back and forth. Now, what we could do to make that exercise more challenging, if we want to go to the next slide, I'm going to talk to you just briefly about how we may put you on 2 balance pads. So you're standing with a balance pad under each foot. I may have you with a scarf tied around your finger so that as you swing those arms back and forth, you have to make those scarves really dance in the air. And then maybe instead of counting out loud, maybe I'm having you name a different animal or a different car or ingredients in a recipe. So that's how we would take it up to the next level. Let's take a look at the next video, and you're going to see another one of the exercises, which is the sideways rock and reach.
You're going to start with your feet apart in a big step and big posture. And once you're there, you're now going to twist across your body with a big movement and then come back nice and big. Let's see Jenny do that one more time. Big posture, twist, palms up, nice and big, and back big.
Great. And you can see how that exercise works on weight shifting, because you're shifting your feet and turning. You're also rotating your trunk. You're keeping the arms up nice and big, so it works on posture. It's helpful for helping people to be able to make turns. It helps people with being able to reach to get seat belts, to reach over to the bedside table, and so many other things. So the next slide, just to give you a description of how we would make that more challenging, is we actually have balance pads that are very long, like a balance beam, and we can have people working on doing that exercise actually on a balance beam. Another way that we make it challenging is I hold up pictures of different objects and different words, so that as my patient has to do that full turn, they have to see the picture, tell me what it is in a nice loud voice, and then finish the exercise. So there's always ways that we can take that and make it more challenging for you to work you in a more complex kind of way to drive that brain change. Next slide. So our LSVT BIG treatment sessions should never be boring. They should never be easy. When you are working with your therapist, they should be as creative as possible so that they can really challenge your brain in order to make that neuroplastic change happen in your brain. So everything that we're doing, the underlining theme is that we keep it big, so that we're not just doing these things for fun, but we're doing it to challenge you, but also that you keep your size of your movement, because we are fighting, remember, that bradykinesia and hypokinesia. Next slide. So those functional component tasks I had mentioned before, just want to give you some examples here. So here's an example of someone I was working with, a 44-year-old woman. Not only did we do the sit to stand, but she also wanted to be able to pull something out of her purse. And if you're like me, I can always lose something in my purse. Even though I just put it in there, it falls to the bottom. So the ability to pull something out of her purse. She wanted to be able to write her signature better, the ability to get that big reach for the seatbelt. And then after she would hook her bra, the ability to turn it around and put those straps back on. Now the difference for someone who's a little bit older, but still in the early stages, 65-year-old man, he wanted to work on pulling his wallet out of his back pocket because it happened to be his affected side on the right, so he kept his wallet on the right back pocket. The ability to remove a backpack, the ability to swipe his card when he would get on and off of the bus, and then being able to pull his chair out from underneath of his desk. So again, these are very personalized component movements that we're doing with our patients, and it's something that you really should be discussing with your therapist to come up with. Next slide. So again, those neuroplasticity principles that we're doing, again, let's think back to the meaning. These are tasks that are chosen by you, and they are things that have value to you. It's nothing that we as the therapist are assigning to you. They are things you want to be able to do, and we're going to help you to do that. Next slide. And again, it's a mental sticky note. We want you to be thinking big about every single thing you're doing, even from the very small task of hitting a key on a keyboard and buttoning a button to large scale things with moving to get out of bed and climbing stairs. You're always thinking about how can I do this in a bigger and therefore much more safe and functional way. Next slide. So this is a great video of one of my coworkers working with one of her clients. This young lady had to be able to open a gate to, worked at a CVS where the gate was closed at night and then it needed to go up in the morning. So here's the therapist working with her, but also making it more challenging by standing on a balance pad.
Left hand and pull. Big left hand and pull. Go for it. Ready? Yep. Go. Big left hand. Left hand. Left hand. Yes! Left hand. Good. And stop. Good.
So it's a great example of how we can take something and still make it more challenging, but still keep it in that functional realm for whoever needs it. Next slide. And the walking big, it's not just like I said, walking up and down the hall. We're doing all sorts of crazy things with you where you are turning and stopping and starting and climbing over things and going up and down steps. We're going to work with you on crossing the street. You know, there's so many things that go into being able to do these tasks. What you see in this little snippet here is this gentleman was having difficulty with the stairs, and this is how we made it much more challenging for him. Something overhead while doing the steps.
Same thing.
And then when he comes up,
Be a fruit or a vegetable on each hit and each step.
I'm asking him now to really multitask, doing the steps, hitting, and moving items.
Beets, corn, peas. Forgot.
Great. Next slide. And then the hierarchies that I mentioned before, let's go back and take a look at those two patients. So for the 65-year-old gentleman, it was taking his backpack down from his locker, placing his laptop in it, being able to put on the backpack, and then walk out of his office. So lots of different steps in there. The second one was his ability to be able to walk comfortably into the conference room, get in and out of the conference chair, the table there, and to be able to write on a board with a marker. So businessmen who needed to be able to get in and out of situations and feel comfortable with what he was doing. And then looking here at the 40-year-old woman, the ability to be able to walk up to the car, open the trunk, take out the grocery bags, then walk with them, open the door, get into the house, and place the bags into the kitchen. So multiple steps that we need to be able to do with that. And then one of her other ones was being able to walk on a floating dock to be able to get in and out of her boat. So being able to manage keeping her movements safe and being able to stay balanced with being able to do that. So very challenging situations for people, and we made it very fun and very functional for them. Next slide. So in summary, remember that in early PD, the pathology is not early. It could be underlying for several years before you actually start to have any of those motor symptoms. And we like to say that community-based fitness programs, while very important, do not replace skilled therapy by Parkinson's disease experts. So we ask you to really seek out a specialized therapist early. Don't wait until the symptoms are more noticeable or problematic. Please don't wait until you're starting to fall to see your physical therapist. And please don't wait until you're really having difficulty being heard until you see your speech language pathologist. So again, begin both LSVT LOUD and LSVT BIG as soon as possible after that diagnosis and really work with us to help prevent that decline. Remember that all of your sessions, whether it's LSVT BIG or LSVT LOUD, should really be focused on functional activities for you, and that your therapist is keeping it very challenging, very meaningful, and very fun. And just like any exercise program, you need to keep practicing this every single day. So we want to encourage you to see your therapists during your lifetime, just like you see the dentist. They're your partners in Parkinson's. Hopefully we're not waiting to go see the dentist until we have a cavity or a toothache. We're going every 6 months, every 3 months to stay on top of our oral hygiene health, and we want the same thing for our brain health. So if you have questions about how to get started with both LSVT BIG and LSVT LOUD, you'll need to talk to your physician for a referral or a prescription for an evaluation. These prescriptions do not need to specifically say LSVT BIG or LSVT LOUD. but you do want to make sure that you have a certified therapist to perform this for you. So you can visit the website at www.lsvtglobal.com, and you can click on the links to find clinicians in your area. Now, there's also videos. You saw a couple of the little videos today of the exercises, and we do have those available to help introduce you into the movements. But I must say that these videos are not a replacement for therapy. They only go over the exercises. They do not go through the actual function that is particular to your needs. Next slide. So remember the tools and resources for you. Like I said, we have homework helper DVDs and also available to stream and download from your computer. There's also something new now called Big for Life and Loud for Life, and these are exercise groups that are taught by people who have been certified in both LSVT BIG and LSVT LOUD, and you get together with a group of other graduates of the program and continue on. So it's a great way to have you know, a nice place to talk to people and to have a real sense of community and to really keep on your P's and Q's with your programs. And I'm going to let Beth talk a little bit more about the LSV Companion and turn the rest over to her.
All right, great. Thanks, Heather. Yeah, so the LSVT Companion is another tool. It was developed, it's a software program that can be used either by clinicians to help to collect the data during sessions or by individuals with Parkinson's to do some of the sessions independently at home. So that's another idea. If it's difficult to get to the office 16 sessions, that's another way that you could do some of the sessions at home on your own with the help of that program. And we've had research to show that the results are similar to all 16 sessions done in person. LSVT LOUD is LSVT LOUD delivered over the internet or telepractice. So if you're working, maybe you could pop in on your lunch break and just do a quick hour-long session with your therapist or right after work. So it can be a good way if you have a pretty full schedule and it's tough to get to the office. That's another way to be able to see your clinician. And so you can also search for LSVT LOUD certified clinicians on our website to see what clinicians are available. And then, so we just wanted to remind you, we do have some upcoming seminars on LSVT. So these are in person. If you live near these areas, we're doing one on LSVT LOUD in West Orange, New Jersey on November 5th, and then one on LSVT BIG in Tulsa, Oklahoma on October 29th. So if you're interested in either of those, we encourage you to go to the website and register, and then you can have a free seminar and free exercise demonstration with clinicians and therapists that are being trained in these treatment approaches. So sorry, I know we're just over time, so I really appreciate you being here, and we'll stay on for about 5 or 10 minutes and address any questions that come through. And I did have a couple questions come through as we were going, so I just want to address those first. And as a reminder, if you do have questions, you can type in your question in the question box on your control panel, or you can raise your hand by clicking on that hand icon. So the first question was just a clarification. We talked a lot about therapists in the presentation. I think this was more from the first half. So what specialty are we talking about? Speech or physical or occupational therapy? And is there a specialty called LSVT BIG or LSVT LOUD? So yeah, in the presentation we covered all three of those therapists. So if you're going to work with someone on speech or swallowing, then you would see a speech language pathologist or speech therapist. And then for the movement, so LSVT BIG, you would see either a physical therapist or an occupational therapist. And so with either of these programs, so either LSVT LOUD or LSVT BIG, the therapists attend either an online training or a 2-day in-person training where faculty members such as myself or Heather, we train them in these specialty approaches, so LSVT LOUD or LSVT BIG. So for example, if you're looking for an LSVT LOUD certified clinician, this is a speech language pathologist that has already gotten at least the appropriate degree. So in speech, it's a master's degree to be a speech language pathologist. And now this person has also done extra training to become certified to deliver LSVT LOUD. And that is important to make sure that you have an LSVT LOUD certified clinician and not just any speech pathologist, if they haven't been certified in LSVT LOUD, to make sure that you're getting the right LSVT LOUD protocol and the one that we teach at the workshops. So again, you can look for that on the website, and you can also talk to your physician to get an evaluation. And then so the same thing with LSVT BIG. So anyone delivering LSVT BIG also needs to be certified. So they need to attend a workshop or have done the online training. And they're going to be either a physical therapist or occupational therapist who has already met the needs and education and experience requirements to become an occupational therapist or physical therapist. And they've taken that extra training to become certified. It's very important for that too, to make sure that they are certified to ensure that you are getting LSVT BIG, just as we described here in the presentation. And then just a follow up to that, so it looks like this individual has said there's no therapist near him, so what should I do? So that is one thing that you could do, is we have some clinicians at the workshops who are there because they have clients waiting for them at home. So if you have a speech therapist or physical or occupational therapist near you that you see, you could ask them if they can get trained in this approach so that they can come back and then do the therapy with you. So if you're interested in LSVT LOUD, one idea could be LSVT LOUD or LSVT LOUD, or doing that telepractice where the sessions are done over the computer. And so you can search for LSVT LOUD certified clinicians on the website and contact one of those. I would encourage you to find someone in your state if you could, because there are some licensure laws with speech pathologists across state lines. So for example, when I was working in Texas, so I had, and then I moved to Seattle, I maintained my Texas licensure, but to do telepractice in Texas, I would have had to do the evaluation in person, and then I could do the 16 sessions wherever I was in the country, or I should say wherever else I was licensed. So I had a license in Washington State and Texas, but I had to do the evaluation in person, and then I could do treatment across state lines. So just it's easier if you can find someone in the same state, but other people may have multiple state licenses. So that's one idea. The other idea could be doing some of the sessions with the LSVT companion, but you would still need to have someone to do some of the sessions in person. So it sounds like for you, those are a couple options. Another option I was just thinking of is we've actually had it where we've had clients who they either have a friend or family member in a big city or a different area where there are a lot of therapists, and they might go stay with that person for a month and do the treatment for a month. So that's another idea. So those are just some ideas. We're happy to talk through other ideas with you or help you find a therapist in your area. So if you do want to email that info@lsvtglobal.com or ask to talk to somebody, we can certainly walk you through some of the options and try to help you find therapists that you can work with. Okay, and I didn't see any other questions come through, but again, if you do have questions that you think of after the webinar, feel free to email us at info@lsvtglobal.com. And then we hope to see you on another webinar. So thank you so much for your time today and listening in and participating. We're really happy to talk to you about this important topic. And we hope that you will receive treatment or educate others on the programs and the importance of receiving treatment early. So thanks for joining us, and thank you so much to my colleague Heather for an excellent presentation.